Good morning. My name is George Taylor, and on behalf of the Tamaqua Area Faith Fellowship Network, I'd like to invite you, yeah. I already did that. I'd like to welcome you to this morning's workshop here at Zion. Just some housekeeping chores. Obviously, the coffee table is back there. The ladies' room is through this door and up the steps, and the men's room is at the opposite end, right? They kept the men and the women apart when this church was built, okay? Same thing. We are recording today's program, and so therefore when you talk back there, I'll be running around with a handheld microphone, so please wait till I get to you if you put your hand up or whatever, because we'd like to have all the responses on our recording today. Anything else, Rosemary? Okay, at this time I'd like to introduce Pastor Cindy White.
Grace and peace to you on behalf of Zion Lutheran Church. It is an absolute delight that we are able to sponsor such an important event here. I'm originally from Philadelphia, and I never am ceased to amazed at how many issues we have here, particularly with the opioid crisis. For all of you that assist, work with, help with recovery, God bless you and keep you well. It has been far too long that this country has ignored this incredibly important issue. So for all of you that are here today, grace upon you. It is our most sincere hope that now that we speak about this openly and that there's not such a stigma about it, that a lot more will get to be accomplished. I want to make sure to thank Lauren Calora, who very much is an example of what recovery is all about. She walks with dignity, pride, and welcomes everyone into Hope and Coffee, which is an excellent example of what a community can do to promote recovery. So Lauren, come on up.
Thank you for that wonderful introduction. I wasn't expecting that, but that's cool. So my name is Lauren Calora. I am originally from Tamaqua. I'm the director of Hope and Coffee on 137 Pine Street, downtown, really just 2 blocks away. We are a nonprofit, community-based and recovery-based coffee shop. We fall under the organization, the nonprofit umbrella of the Tamaqua Area Community Partnership. Our fellow organization is also the Tamaqua Area Arts Center, Community Arts Center, which is 3 doors down from us. We serve to normalize and destigmatize recovery from addiction, primarily in Tamaqua, but also in surrounding areas. We hire people in recovery, primarily, and we are a very safe place for anybody in the community to come enjoy a good cup of coffee. We have lots of baked goods, we have food, we have homemade soups, breakfast sandwiches, and locally and freshly roasted coffee beans that we're very proud of. We have so far had 15 to 20 employees since we opened about a year ago. We celebrated our 1 year in July, and we have had 5 of those employees move on to full-time jobs. So we're basically a stepping stone for people in recovery to gain some job skills, be incorporated into the community in such a positive way, and really, like I said, create a safe place for people to go and enjoy themselves. All of the components of Hope and Coffee are mainly to destigmatize recovery from addiction. However, if you take a look at the model that we use, it really is a lot of components that are what it takes to promote long-term recovery. Everything from community to a healthy place to go, non-judgment, getting people involved. We have employees that have gained trying to think, classes at L-Tri-C. We put people in non-credit courses to gain skills and education. And we work very closely with Safer Streets for Tamaco's Little Feet, another local organization, and as well as the drug court system, and local treatment centers, churches, whatever we can to do as much outreach and gain as much positive empowerment for anybody that walks through our door. A lot of people say, you know, that place is just for people in recovery, which is one thing that really gets under my skin, because it's not. It's a community coffee shop. If you want to just go get a cup of coffee, go ahead. But we're primarily there to normalize what it means to be in recovery from addiction. I'd like to just point out that one of our employees is here with me, Melissa. She's actually not in recovery from addiction, but she's very incorporated into her church in the community. She brings a very important piece to our coffee shop. She does a lot of extra work for us, and so we try, like I said, we're normalizing what it means to be in recovery. So we have people not just in recovery from addiction, but people of all walks of life. It's just a matter of getting everybody together and working on the same goals together. So, thank you.
And now it's my pleasure to introduce Rosemary Lister. She is the Network Director, Community-Based Health, Rural Health for St. Luke's University Health Network. I'm going to talk here.
I'm going to introduce Greg when I'm done, right?
Yeah.
Hi, everyone. Thank you so much for coming. I cannot tell you, can you hear me? Mm-hmm. How excited I am to see this room filled. Usually when we have events and we ask people to pre-register, we get half. So this is really a couple of different testaments. It's testament that you care. It's a testament to the strength of your community. It's a testament that there's a need. We have a lot we need to do. But we can do it if we work together. And I absolutely love working in these communities in Carbon and Schuylkill, because I see this a lot, and it makes me so happy bringing people to the table to really look at what their need is and then say, how can we do this together? So I just want to thank you again. I will be bragging about this group for a very long time. I have seen each registration come in, and I've been updating the charts, and I've been working with Dave and George, Dave Fetterman and George Taylor on this, so I just want to thank them. And every couple of days I'd send them an update, and it just kept growing and growing. So it was really exciting, but not as exciting as seeing it in real life today. So thank you, thank you, thank you. So at St. Luke's University Health Network, we do community health needs assessments, and that's because we're a nonprofit hospital. So we want to be that community partner. And every hospital that's nonprofit has to do this every 3 years. But we do it a little bit differently than some other hospitals, because we really invest in our communities. And I have to say, actually our CEO has a public health degree. Many people don't know that. But he's always been passionate about communities, investing in communities, and working together to improve health outcomes. And my boss is a preventive medicine doctor. Well, I have a lot of bosses, but that's one of them, and then also an epidemiologist. So they kind of do a hub and spoke model, where we do a big assessment in all our different communities, but then we kind of branch out and we build partners and we build relationships, because we are not the experts. You are the experts. So we just kind of build capacity and then ask you and to identify other partners and how we can continue to work together. So that's just a little bit about our department. I'm gonna talk a little bit more too, but I wanna ask you all a question. What makes us healthy? I know I'm the first one, and maybe you're not so interested. So I'm gonna, pass this in. Very good. Anyone else? And I love that that's where you went from the beginning. Oh, I'm sorry. She said our environment, which was very insightful. Yes.
Having positive relationships.
What a group. Wow. Exactly. If we were maybe with a different group, what might they say? Money. They might say money, and they might say genetics. We hear a lot about that. But yet, what makes us healthy is our communities, our education, our experiences. And there is obviously some family income and so forth, because there's a lot linked to your health status and your access. But if you look at this, has anyone ever heard of social determinants of health? So if you look at this circle in the middle, that's what most hospitals and health focuses on. Individual factors such as your genetics, and then individual behaviors. But if you look at the outer rings, that's our community, that's our education, that's our barriers such as transportation, that's all the different things, housing, access to food, that makes up. Sometimes 70 to 80% of our health is identified by those outer rings. And that's why we are in the communities, and that's why your involvement is so important, because your capacity to influence health and connect families in need to health is so important. So again, I mentioned we do these assessments. We go out in the community and we look at data. We look at existing data such as coroner's reports, such as census data. That's called secondary data, and that is gathered on how we die, how we live and how we die. Does anyone know what the number one cause of death is? Number two, what number one or number two? Heart disease. Next is cancer. Next is stroke, complications from diabetes, and so forth. But when we go out in the community and we collect what's called primary data through focus groups, through key informant interviews, what do you think we hear? What's that? Well, we hear substance use disorder, yes. We hear mental health. And that doesn't matter what your education or what your income is. We hear that across the board in all of our communities. So in Carbon and Schuylkill specific though, this last summer, we went out and surveyed the community, and we were able to get over 900 surveys completed to really find out from the community what the needs are. So you see the breakdown there in Carbon and Schuylkill. And 3 years prior, we had only had 300. So we're really trying to get out there, and we're trying to work with you to get out there. So you might hear from us next cycle. We may say, can we come to your location? Can we survey? Because it's important for us to know what the needs are in the community from the community. But then once we find out those needs, our job is to build, again, the partners and the capacity to improve the outcomes around that. So what is the need in the community? So let's look at the biggest bars there. The blue one is Schuylkill County, and the beige one is Carbon County. And that's the ratio of population per mental health provider. Is that a surprise to anyone? So here we are as a community dealing with a substance use, opioid use epidemic, and yet we have a lack of providers. That's a challenge. That's why we need to train as many people as we can. Ideally, it would be great if we can make this bar very low, and that is a goal. I mean, we have a grant now where we wrote in additional providers, but that's never going to be enough. So we need boots on the ground, able to identify, connect, screen, and refer to treatment, and understand. Poor mental health days, and these grades are kind of hard to understand, but we are higher than everyone else in our network for those that report poor mental health days. Surprise? Okay. Improving mental and behavioral health. This is also a grid that might be difficult to understand. Lots going on because it's looking at all of our St. Luke's campuses, but the very top one, this is rates per 100,000 of opioids death per year. So that is Warren. Warren's really high, but the next high is Schuylkill. That blue line is Schuylkill, and then right underneath that is Carbon. So does anyone know where we stand in the nation for opioid overdoses? We're third, yes, we're third. It's West Virginia, Ohio, and Pennsylvania. And then, so we're third in the country, and then our counties are up there as some of the highest. Carbon County had one of the highest rates of non-fatal overdoses. Okay, we also have vaping. That is obviously becoming an epidemic proportions. And then we also have self-harm. We can't overlook mental health in all of this. Anxiety, depression, all of that, it's here, it's in our schools, it's in all different sectors of our community, and this is basically the breakdown for youth here. How I met Greg, kind of jumping around a little bit, but I went to the Northampton County faith-based training, and there were 51 people at that training, which I thought, wow, that's amazing. So that's another reason why this is such an amazing group, because I think we have 40 people here right now. But when I met Greg during that training, I actually went on behalf of the Northampton Suicide Task Force, because I'm part of that. So for St. Luke's, I'm rural. I work for St. Luke's Naden and Palmerton and Miners and the new Geisinger St. Luke's campus, so for Carbon and Schuylkill. But for St. Luke's Network, for the Community Health and Preventive Medicine Department, I'm helping them look at best practices for all of our counties for mental health, behavioral health, and substance use disorder. So Northampton County, we're looking at that suicide task force and what a great job it's doing and how we can make sure we are engaged at all of our campuses in suicide task force. But we went to that to make sure everyone in the group knew that you can't look at substance use disorder alone. You have to also look at mental health. There's so many co-occurring situations that we have to be aware of, and that, yes?
I have a question.
Yeah.
What connotes self-harm? Is it just suicidal attempts or cutting or what?
All of it.
Okay.
So they have surveys where they ask all of that. And actually, I have the link, the previous slide. I'm going to email this PowerPoint to everyone, and you can look at that data more closely with the link that I have. What we do is when we do these assessments, they're for the community, so they're posted on our website. So you can look at past years, this year's. It's plenty of data to always look at. So again, we know that there's an epidemic going on, not just opioids, but substance. So when I say substance, I mean alcohol, I mean methamphetamine, synthetic marijuana, we mean all of it. And we go out and what's our main goal? Our goal is to reduce the morbidity and mortality, as it says in our community. So we look and say, okay, we can do this, but how can we improve our reach? So one of the things that I've done is try to look at grants that can help us bring along more capacity to work together. So we had, Kay Jones was part of this planning grant that we had, and many of you here, where we kind of spent a year to look at what can we do for prevention, treatment, and recovery. And we had core activities that were our deliverables around that. And that was partners that really have legal agreements together to work and sustain their efforts. And then we did another analysis. So here we have our community health needs assessment, but then we went out in the communities and we did 6 focus groups. And we did our focus groups with our partners. So we did one with Interfaith Health Network in Schuylkill County. We did one at Panther Valley School District, which has really been hit hard with this epidemic. The elementary school alone had 11% of the students there being raised by grandparents or another caregiver. And then we went to Child Development Head Start, because they're also on the front lines, as well as Pastone Head Start, and Schuylkill County Vision, which is a collective impact group in Schuylkill. And we had focus groups with them, as well as Penn State Schuylkill. And guess what we found when we did these focus groups? When we said, what are the barriers, what are the challenges, and what are the strengths? What do you think we found as a major need? Thank you, Dave. Stigma. Raise your hand if that's a surprise. It's really not a surprise, but we found stigma even in the recovery community about people having opinions about how someone should have recovery. There's stigma in healthcare. There's stigma in our communities. There's stigma probably in our parishes as well. It is everywhere. So that came loud and clear. So I just went over the grant partners, and we have a steering committee. We have faith-based partners in our steering committee. We have advisory council. If you want to be part of any of that, just let me know. You'll have I'll follow up with everyone in email. So there's always ways to get involved if you want. So basically, this is a little bit more about our year that we spent planning. And we also did a survey to our advisory council, and we came up with some interesting data from that survey. Number one, we found that the greatest barrier was access to services, which was transportation. Then we came up with trauma-informed care. Does anyone know about trauma-informed care? So trauma-informed care is something that we're going to be doing a lot of in the community, and it's basically looking at adverse childhood experiences. So we get a greater understanding of not what's wrong with Johnny, but what happened to Johnny. Trauma, and I don't have all the statistics with me right now, but trauma is very related to chronic disease and substance use disorder later in life. So there's a lot of research on how trauma affects our future. And we'll be out there doing a lot more in healthcare about trauma and schools. One of the things we wrote in our plan for the implementation grant we currently have is to have trauma-informed trainings at every school district in Carbon and Schuylkill. So with the grant, we can cover rural communities, and there's some Carbon that's not rural, but we're asking like United Way to help us with that and different partners. So this group, we can keep in touch if you want, and as we have different trainings we do, that might be something some of you are interested in. So then we also have warm handoffs that came out. And does anyone know what a warm handoff is? Okay, warm handoff is healthcare doing a better job of when someone admits at our emergency room with substance use disorder, that we are there and we say, we see you have substance use and so forth, we can connect you. We can connect you to treatment. We can connect you to services while you're there before you leave. So we have it in some level at all of our campuses, but we're very committed internally to try and make that even better and improve that. It's not easy because transportation is always an issue, but we're looking at ways we can improve those obstacles. And transportation is something we all have to think of. We all have to think more innovatively with transportation because that's the only way we're going to get anywhere with it. So keep that in mind, Lyft drivers. If you have someone who might be interested, we can get them a package on how they can become that, provide that service up here in the community. And then again, stigma came up. So we have some of these postcards here, Surgeon General postcards. We can have some education materials available to you at any time if that might be helpful, as well as local information. And then we have an implementation grant now. We're very grateful that we have this opportunity because we can do more. Money doesn't solve everything, as we know. What's the most sustainable factor is this type of commitment, but it does help jumpstart certain things. So that's what we have a plan to do, to use different funding to kind of start doing more something called medically assisted treatment with social work in tandem, because medication alone doesn't work as well as medication with social work, with licensed clinical social work. And then we have funding now to do trainings. There's a couple different trainings. I'm going to mention a couple because, again, I might come back to you and say, are you interested? So there's one that's called SBIRT, Screening, Brief, Intervention, Referral to Treatment. We are going to be launching that internally within our health network and looking to do it in our communities. Another one is motivational interviewing. Has anyone ever heard of motivational interviewing? Okay, so drug and alcohol is doing some of them, and we actually have all of our rural health centers trained in motivational interviewing. It helps patients have goals about what's important to them. So let's say they have diabetes and they want to improve their health outcomes. We might say to them, we'll set up a goal, and what might be important to them is playing with their grandchild. So motivation in interviewing is working with them to set goals on what's important to them. So then we actually have charts in our medical records on how we can assist them and, okay, could you walk more to then build up your endurance to play with your grandchild and so forth. So we're going to be doing trainings like that. There's also ones called mental health first aid. Has anyone? Okay, so there's already people in the community doing that, so we're going to reach out to them first and say, can you come along with us and help train our communities? And if they have capacity to do that, we'll let them do that. No sense in reinventing the wheel. But if they don't, we'll have some master trainers trained here. Question, persuade, refer. Has anyone heard of that? Okay, we just did that, our Carrie Quick, who's our community health worker, just did that for Panther Valley School District staff yesterday. Renee, which ones? Am I forgetting any others? Certified recovery specialists, we have partners that do that. So there's trainings that come along with this. But here's our goals. It's to increase those that are screened and connected to substance use disorder services, and increase providers, as well as, this is where you fit in, the third one. Increase the number of community members who receive general substance use disorder education or training. So we're doing this now, but we can continue to do that. And then healthcare staff as well. And then we have some long-term outcomes. So what I don't have on here are the national and state rates, which I should have put on, but if you look at these rates, so right now in Schuylkill County, 24.5% per 100,000 is the overdose rate. The national average, was it 17? And then the state was like 13 or 14. So we are really high. So we have some very specific goals to reduce the amount of morbidity and mortality with this epidemic. And then here's our 3-year goals. So we would like to demonstrate an overall reduction of 50% in Schuylkill County and 33% in Carbon County. And to be honest with you, when we put these together, I said, let's go for bold goals. A bold goal is to really inspire us to go in hard. And I said, can we get this down to the rate it was before we had this epidemic, which was like 3 per 100,000. But it's hard because I think we have to shoot for 0. I mean, we want 0. We don't want anyone to have to pass away from an overdose. But then again, sometimes with statistics, you have to be realistic. So I say this, but I want us all to think bold. Let's think bold. We have a lot of work to do, and I think we can do it. When you get this PowerPoint, I have some key people at Carbon-Monroe-Pike Drug and Alcohol and Schuylkill Drug and Alcohol. They are what's called a single county authority. So they house a lot of resources. So I feel like they're the key people that you need to know and the key numbers. You can also always reach out to us. I'm going to send you a directory of our advisory council that we pulled together because we know a lot of people who are doing things in the community, but there's also a lot that we probably don't know of. So please know that you're going to have my contact information. Let me know if you think of something or someone that might want to get involved. And again, if you want to get involved, we absolutely have opportunities, or if you want to just stay in the loop. And I'd like to turn it over to Greg now, but I'd like to thank Greg for coming up here from the Lehigh Valley to offer this training. We really appreciate it. I think you're going to really enjoy today. And I'd also like to thank Zion's Church and George and Dave and, again, all of you. This has been amazing. Does anyone have any questions for me? Okay. Well, then I'm going to just give you a short bio on Greg. Well, it's really not that short, but it's a really incredible bio. He's been doing a lot, and we're really happy to have him here. So Greg brings extensive experience in the addiction field to his work as a director and a licensed professional counselor and CAADC. He is the director of Mid-Atlantic Rehabilitation Services, which is also called MARS, and they're really involved in our warm handoff in the Lehigh Valley, in Bethlehem, PA. He is co-owner of Monocacy Counseling Associates. He is the adjunct faculty member at Moravian Theological Seminary. He's a consultant and trainer with the Council on Compulsive Gambling of PA, and he is a Department of Drug and Alcohol Programs approved trainer. He has been a counselor and program director in the addiction and mental health counseling field for over 23 years. At Moravian Theological Seminary, Greg teaches motivational interviewing, addiction and the family, and introduction to addictions. Greg currently provides training in screening assessment, basic HIV, TB, hepatitis, STI, and many other topics as requested for DDAP, which is the Department of Drug and Alcohol. Greg has extensive background in program development, having been with MARS for the past 12 years. He has led numerous aspects of licensure throughout his time at MARS and previously in his career. During that time, MARS has implemented numerous programs and expanded its capacity from 35 persons to serving 350. And you're welcome to expand up in the rural region if you would like.
Yeah,
So-
we're up to 450 now.
450. We can improve your numbers. So thank you, Greg, again, and at this time, I will turn it over to Greg.
Thank you. It'll just take a minute to switch to the other PowerPoint, which you should have gotten when you came in. I usually don't need a microphone to speak, but I'm using the microphone because it's being recorded for you so that people can see this who weren't able to attend. A couple just technical things. You have an agenda in the schedule. We'll take a break at 10:30. This afternoon, after lunch, you'll hear from the great people at the single county authorities, both Schuylkill and Carbon-Monroe-Pike, and they'll be talking about the services that are available right in the communities and in the counties that you're working in. A couple other things, when I trip over something during the training, because I can't sit still and I move all over the place, feel free to laugh, because I'm going to laugh at myself when that happens. As we go through that and go through the day. The other thing I ask, I know you all have very important jobs as leaders in your faith communities or the other jobs you do. If you could make sure that your cell phones are set to vibrate, because the rule in my training is if your cell phone goes off during the training, you have to stand up and dance for everybody until it stops. So if you could just do that for us so that we can take care of that as well. It has been wonderful working with all the people who planned this to be here today. This is the third time in the state that we're doing this. Started out with Lehigh County, then Northampton County requested it, and now we're up here. I love being here. I've been in the field, like my introduction said, for a significant time. I graduated from Moravian Seminary with a degree in pastoral counseling in 2002. I was pretty sure once they got rid of me, they weren't going to let me back in. They decided to have me back as an adjunct, and I teach there now when they have a need for that. Part of what's important in understanding what Moravian's doing that's different than a lot of other faith-based educational institutions, less than 10% of faith-based educational institutions for our faith leaders offer any kind of coursework or education in substance use. Yet in a study called So Help Me God, which was done in 2010 by Casa Columbia University, close to 90% of faith leaders identified substance use as a problem within their communities that they're working in. So it's an important issue. I am so happy to be speaking with you today. I have a whole bunch of slides in the PowerPoint. We may or may not cover every single one of them. It's okay. I want to make sure that you get information that's useful and helpful to each of you. So I want you to ask questions, stop me, interrupt me, share the knowledge that you have, because I think as a group, we always do better when we share what we know and we can learn from each other than just by being lectured at. Because if you just sit there and stare at me all day, I'm going to be really bored. And it's much better off when there's interactions and discussions. So we're going to look at the topic and get through it. For those of you who need certificates, you should have signed up with the training management system through the Division of Drug and Alcohol Programs. And that's where you would go into to fill out whatever you need to get a training certificate. So we're hoping that you can understand, because a lot of times when we talk about addiction, you have different groups of people who look at it and think about it. You have a group of people who thinks it's a medical problem, and the way to fix problems with substance use disorder is to treat the medical aspects of a person, the biology, the physical aspects of it. And we do a good job of that. There are options and opportunities for medication-assisted therapy for people to help them with withdrawal symptoms from the physical illness they're going to experience, and to help them see that. There's some people who think that's all you need to do to fix substance use issues because it's all a biological issue. You have other groups of people who believe that it is all mental health and in our brain, and that if we fix the thinking and the behavior of the person, the substance use disorder goes away. You have other people who believe it's a social problem, and if you fix things in the environment, people's education, their knowledge, their community, the issue goes away. And you have other people who for a long time have taken the stand of just say no. And if you don't start, you won't have the problem, and that's how we fix it. I grew up in the 80s with just say no. If it worked, I wouldn't have a job because nobody ever would pick up a substance. What we have to realize is that all those different groups have something to offer to the recovery of a person. And each person, their recovery is going to look a little bit different. And the piece that we can't ignore is the spiritual aspect, because I believe that is essential and central to all of us as people. And if we don't address the spiritual in a person's recovery, they're going to turn back to the substance as their answer to all of life's problems and try to solve it. Substance use in general is an attempt to solve problems. It's somebody's effort to fix something that's not working and going well for them. So we have to look at and make sure we deal with the whole person. And what better group than you to address the spiritual aspect of substance use and addiction with your faith communities and the people who need it. We need to get groups and coalitions together to make things work in a better direction. We can do certain things as a treatment provider that will help people in recovery and make recovery not just possible, but probable. We can't do it all. Treatment only lasts a certain amount of time for people. Community groups, community-based interventions where people are living out their life is necessary to help them on the path to recovery. A lot of times people think recovery might happen or it could happen. The reality is, with support and connection, it's more than just possible. It's very likely that it will happen for people. So we have to start to look things differently. One of my favorite authors is Gerald May. I have a couple you'll probably hear me talk about today. Henry Nouwen, from a spiritual perspective, and Gerald May, who was a psychiatrist with a very strong faith background. He wrote a book that I use in my addictions class called Addiction and Grace. It's one of the best books I've ever found that addresses and deals with the issue of addiction and recovery and the importance of grace and connection in somebody's ability to make the changes they need to recover. So one of his quotes is, "Seek the truth, not what is comfortable. Seek the real, not easy." We often get stuck because substance use, like Rosemary mentioned, is often continuing to be stigmatized. It's still in the background. It's still hidden because people are afraid of what the response of the community is going to be in the midst of their struggle. Plus, people often, in the midst of their substance use, have been trying everything they can think of to stop. Actually, one of the diagnostic criteria in the Diagnostic and Statistics Manual, 5th edition, best way I can describe it is it's basically the Bible for mental health, and has every possible mental health concern that somebody could have. It's probably about 4 inches thick. Bring it to a family event and have fun reading through all the diagnosis in your family. It basically lays out for us all the things that could happen to us from a mental health perspective. And one of the criteria for substance use disorder is have made multiple attempts and efforts to cut down on my substance use or stop it. That tells us something really important. Even when somebody is in the midst of continuing to use substances, they want to stop. They want things to be different. They may not act like it. They may not present that way. But if one of the diagnostic criteria for us is that multiple efforts to stop, tried to stop, cut down, reduce use, change it, is part of what makes it a problem, everybody at some point wants to stop. The key is, when we're that person in front of them when they're ready, we don't have to fix it all. What we have to be able to do is know where to get them so they can get the support and help that they need. And the issue of stigma is shown over and over again. Pew Foundation just did a research study that was released. It's on the Division of Drug and Alcohol Programs website. They studied Philadelphia as an area, and they asked people a question. And the question that they asked people was, what causes somebody to have a substance use addiction problem? And I thought we were doing a better job of getting people a different understanding of things. Over 50% of the people they surveyed still said that addiction is caused by the person and the choices that they make. Over 50% look at people with a substance use issue and say, it's your fault you did this to yourself. Yet we know from a factual basis since about 1954, when the American Medical Association classified addiction as a disease, it's not a new concept. 1954 was when it was first said this is a disease and a disorder for people, not a personal failing. Yet a lot of people's response is, you did it to yourself, you get what you deserve from it. I've read news articles online recently that is about somebody's overdose death. And the comments are, good, one less person to pollute the gene pool. You stick a needle in your arm, you get what you deserve. Those types of comments are still what people are thinking about this issue. And the reality is, the people with this problem are our brothers, our sisters, our mothers, our children, our fathers. There's not a group that this issue doesn't impact and affect very directly and impact very strongly. Martin Luther King Jr. said, darkness cannot drive out darkness, only light can do that. Hate cannot drive out hate, only love can do that. Part of the way to solve this problem is to talk about it. In your faith communities, preach about it, talk about it. Open your communities to places people can go. It makes a difference when the leaders in the faith community talk about it openly, and people can see it's okay to have this problem and still have faith, and have this problem and still be part of a faith community. We have to show that we understand it. Not that we have the answers to it, because I don't believe any of us have all of the answer to it. But when these things come out in the light, they can't hide anymore. They lose some of their power and control over us when we're open and honest about the issue and problem. Overdose deaths, like was mentioned, we've bounced back and forth with Ohio and West Virginia as the top 3 states in overdose deaths recently. A couple years ago, we were number 1. Now we're number 3. Not something you really want to be in the top 5 in as a state. There were enough prescriptions a couple years ago in the United States that every adult in the country can take 1 opiate pill every 4 hours, and we wouldn't run out for 30 days. Every single adult. Pennsylvania, and it started to shift a little bit because of prescription drug monitoring and some other things we're doing from the prescribing end of things. Pennsylvania, just a couple years ago, had 88 prescriptions for opiates per 100 people. West Virginia had somewhere in the range of 130 prescriptions per 100 people in the state. United States is 5% of the world's population, 5%, and we consume almost 90% of the opiates in the world. It's not just the medication and prescribing that's causing that issue. We're going to watch a little later this morning a video that's a TED Talk, so it's about 15 minutes long, called Everything You Thought You Knew About Addiction Is Wrong. It's by a gentleman named Johann Hari. He wrote a book called Chasing the Scream, and he talks a lot about how our typical approach to addressing addictions has not been effective, and some of the ways we have to look at it differently. And he recently, and I can't remember the name of it, just published another book on addressing mental health concerns from the same perspective and trying to look at them a little bit differently than we have traditionally in the process of it. Brene Brown, who is an author who does a lot of work around codependency and some other recovery issues and some stuff around health in general, said a deep sense of love and belonging is an irreducible need of all people. We are biologically, cognitively, physically, and spiritually wired to love, to be loved, and belong. When those needs are not met, we don't function as we were meant to. We break, we fall apart, we numb, we ache, we hurt others, we get sick. Substance use problems, like so many of our other problems, are an attempt to deal with isolation, separation, and disconnection. When we feel like we don't fit, we're not good enough, we can't be a success, maybe because we've been told that forever and ever, finding something that makes us feel like we can tolerate life in the moment now becomes very attractive to us. Something that makes us feel connected to a group. Something that makes us feel we're part of something bigger, that we're attached and connected to something. We turn to that and look for that as an answer to our current problems and struggling. We know what the answer to that is. Connection with God of our understanding, higher power, God, however we refer to that. That's where we're meant to connect and to live out that connection among people and among each other, with each other in groups. Part of the reason 12-step programs work, it's people being connected with other people who've had the same struggle so they can look at each other and go, it's not just me, you too. And can connect with somebody and say, I'm not alone. We believe we're the only people having these struggles. Our mind and our thinking and our thought processes convinces us that nobody else understands it, nobody else has it, we're the only one who has it the way we have it. And the reality is, when we take the risk of putting ourselves out there to people we realize we're not the only one. One of the things I love about Gerald May in his book is that he's got 2 or 3 pages in the book. That's like 4 columns on each page that lists all the things that we could be addicted to. And I love when my students read the book and they're like, I have that one and that one and that one and that one in my life in some way. Every single one of us at different points is and looks like the addict who sits in front of us. We all play that part, and I think that's part of the reason we have such a strong reaction to it, because we look at the other people and go, I wish somebody would stop you. Johann Hari uses that kind of language too. And I think the problem is that what we're doing when we do that is we're looking at ourselves and going, I wish somebody would stop you, me, I, from whatever that behavior is that's causing us challenges and difficulties. We all have those behaviors at some level. We all attach ourselves to something that's unhealthy in the process of things. So this is one of the things that tends to happen to people overall, is that we take this look of this kind of story of the elephant, where they talk about they have a bunch of blindfolded people looking at the elephant, and some of them, grab the tusk of the elephant so they think it's a spear because it's sharp and pointy. Other people grab the tail and think it's a rope. Other people grab the legs and think it's a tree. They'll grab the trunk and think it's, but we don't often see the other pieces of it. This is called the silo effect, where we see from our perspective and our perspective only what's going on and what's happening. So we describe it as what it looks like. And this is what's typically happened around addictions, like I talked about it just a little bit ago. The medical field sees it as a medical problem. The mental health field sees it as a mental health problem. We all see it from one perspective. And the reality is we're all right. We're all correct. It is all of those things and more. It's a complicated issue because we're complicated, complex people. If it was an easy solution, we would have found it and fixed it. Somebody used to tell me, one of my old supervisors, all the easy problems are fixed. Because if it was easy to fix, we would have done it and taken care of it already. So we have to watch and pay attention to those types of things to make sure that we're not getting in those silos. One of the places to kind of looking at it, there's a political piece to this too and how it's dealt with and looked at. There's all sorts of things we believe around it. There was a film that was put out in, I think, the 1950s or 60s called Reefer Madness. If you haven't seen it, go look it up on YouTube. It is very interesting to watch. It was an attempt to convince everybody that marijuana was going to drive them insane and kill them and make them jump out of windows and have sex with everybody they ran into. It was an attempt to get people not to do it. Scare tactics don't work at all, no matter what it is. Trying to scare somebody into changing their behavior doesn't work. But we've taken this piece of, we want to identify the one thing that makes substance use a problem. We want it to be one thing. Henry Nouwen talks often about how difficult compassion is and how hard and challenging it is to have compassion for another person. Because our natural human instinct in the face of a problem is to say, do this, fix it, and walk away, and try to pull away from it as quick as possible. Those of us, like all of you, who choose to sit in the hurt, the pain, the suffering of somebody else and show that compassion by sitting with somebody is an unbelievable hard job to do that and be able to do that regularly. we want that one root cause because there's one answer to the problem and one solution. There's been places where in the past the substance use field has looked at the issue and said, if you're on a medication-assisted therapy, you're not really in recovery. Some of that view, so there was even stigma against people in recovery by the treatment field because you're on that. People misinterpret in the 12-step programs occasionally that if you're on mental health medications, you're not really in recovery. And that's not what the 12-step literature says at all, but people develop that belief. We have to take a much broader view and make sure we address the needs of the whole person, not one individual in the process of things. So we want to look at that. There is a survey that's done every 2 years in Pennsylvania. It's called the PAYS survey, P-A-Y-S. It's the Pennsylvania Youth Survey. And they do it every 2 years because they want to track the students through their whole time in school. And they look up and they track what's great about PAYS, if you look it up online, is you can break it down by county. And they'll compare your county to what goes on statewide. And you can look at any county separately. And they may have a big downloadable report for the counties, but online you can look at different questions they asked. I love it because I love data. I'm kind of weird that way. I love numbers and looking at them, even though I hate math. I love statistics and data because it helps inform decisions of how to address things. One of the most interesting things that's coming out of that survey when you look at it, and they talk to different age levels up through senior year in high school, is that our youth, a large percentage of them identify being depressed almost every single day. A large portion of them think that they're no good at all and describe their feelings about themselves that way. A large portion of them identify that they've been criticized or put down by people and have thoughts of hurting themselves or attempting to complete a suicide, and those thoughts. If that's what they're feeling, is it any wonder that they turn to substances to connect with other people who are using the substance and feel part of and not get criticized? Johan Hari's going to say it too, but we are the most connected society in history with phones and social media and ways to get information and data. But we're also the loneliest, most isolated and separated society in history and feel alone. There's a Broadway musical that's been around for a couple years. I just went and saw it with my daughter because she loves musicals, called Dear Evan Hansen. And a huge part of that musical is talking about the issue of youth anxiety, depression, and suicide, and dealing with it in an unbelievably effective way through a musical. It's funny, the musical, but it's also very, very serious. And one of the big parts of it is a song that talks about you are not alone and the need for that connection and to feel not by ourselves and to have places where we can just be us and ourselves. I can't remember if the musical was done first and then they wrote the novel, or they wrote the novel first and then changed it to a musical. I can't remember which order. But they've also now made a novelization of the musical. Mm-hmm. Mm-hmm. Yeah.
And that really says a lot about this community.
Mhm.
And not only that, there's a lot of organizations that are working with school programs to reduce the risk factors and build up a protective factor.
Yep.
So we've seen some great progress, and the contacts that I have on that PowerPoint are the key people that are helping those programs happen. And then we have some grassroots organizations called Step Up. So again, if anyone's interested in learning more about that, they can let me know and I can connect them. But that is something that we can keep building off of.
Yes, and the good thing about the PAYS too is that it asks about those protective factors and shows what things they found to be protective factors, including participation in faith communities, and other things at school, having adults who are involved to care and connect with people. All sorts of things. They look at that end of it too, not just the problems in the community. They look at what are things that protect people from initiating substance use. And what's interesting, nationwide, one of the things they found that is most interesting is that dinner with your family one night a week is considered a protective factor to the initiation of substance use. Not every night, one. And it's because you have a different conversation. I think as faith communities, we've understood that for a long time. I mean, I'm currently American Baptist, and there's food at everything. There's something about sitting down and having a meal with somebody that makes something different and allows us to connect different and have a different kind of conversation. But they found lots of things like that. Having a coach, adult, somebody who connects and tells you you can be something more than the circumstance you're in makes a big difference.
I'm pretty sure that my daughter just took that survey. She came home yesterday and was talking to me about it. And I asked her, just to let you guys know, I said, did you answer it honestly? And she said, well, yeah, because it's anonymous. So the kids are answering it.
Yes, it is anonymous as a survey, so there's no way to connect it back to who does it. And you know, the more school districts that participate, the better we can get numbers and understanding of what happens. One of the issues currently with the PAYS is Philadelphia doesn't participate. They do their own separate survey. So statewide numbers are going to be impacted by some of what's showing up there. In terms of just the number of students that are in the city and not in it. But the PAYS is a really good, helpful, useful survey for us to take a look at and make sure that we're making the progress. So SAMHSA, which is the Substance Abuse and Mental Health Services Administration, has put out a pamphlet that they looked at and studied and tried to say, okay, for clergy members from whatever faith background they are, what do they need to know and understand in order to be effective in addressing the issue in their faith communities? And they came up with a list of competencies, and they worked with clergies who were practicing actively, and looked at and tried to just come up with what they are. And what I'm hoping we cover today is most of these competencies and get you the information you need to be able to implement and use these things in your day-to-day work with your faith community. One of the first ones they identified is be aware of the definition of alcohol and drug dependence and the stigma that's attached to it. We've talked about the stigma. We're going to talk about definitions shortly. And only a physician's group could come up with a short definition that's like 3 paragraphs long. Their long definition is 15 pages. We're going to look at the ASAM definition, which is the American Society of Addiction Medicine, which was written by physicians who specialize in addiction work. Then we're going to look at Gerald May's definition and some others, but we're also going to have you think about, look at, and identify what you see and think about as the definition. We want to look at how do you tell if somebody's struggling with a substance, understand what some of the signs and symptoms of it are, withdrawing from people, avoiding services when somebody's been regularly attending. All sorts of different things start to happen, withdrawal from relationships that they've had before. All these kinds of things lead to and connect to there being a significant concern for somebody, along with other things like jobs and money and those types of issues. Yes?
Justin, there are a lot of us here. There are a lot of folks here who are not clerks. This is quite adaptable then. So
Yes.
church workers, childcare,
Yes.
all this.
Yeah, I believe that although they say these are core competencies for clergy, I believe any faith leader can follow and use and implement these same things in a way to do that. That's why we wanted it to be focused on not just clergy, but faith leaders who are going to be working and implementing work with people with substance use issues. So yes, I agree very much. It can be applicable to lots of groups of people. They wrote it specifically for clergy in terms of what they put the manual together for. But these competencies, I think, are important in anybody who's going to be providing congregational care or other types of faith leadership. Yes?
So I don't want to throw you off the rails here. Just a quick story on something related to the statement. I was asked to speak at a church, and I did. So I represent an organization that speaks on substance abuse, both in schools and to churches, non-denominational. And I went there to speak to them at his request, the pastor's request, because he told me he had several families suffering from addictions in active situations in their congregation. He needed help on how to deal with it. And so I'm not an expert on anything here except I had addictions in my family, so I could speak to that. So I went there and I spoke. And I discovered I couldn't do it in one session, so I told him I'd come back. And I gave him a workshop on addictions. And during the course of the workshop, two of those families that I was talking about were there, and both of them came to a point of conviction where they realized what you were talking about earlier. I would like to fix this, but I don't know how. And one of the objections that came up from one of the key people who's there that we felt was a turning point person, if he got fixed, everybody else is going to follow suit because he's a leader also. He was afraid that his job would be in jeopardy because he works at a college. And my response to him was, I don't know how to solve that problem. But your faith community that surrounds you, this community of church believers that are your family, can become a great help to you if you choose to take this path. And so that's where we left it. And he told me later that that in itself was enough to help him make the next step. So we'll see. I mean, I don't know that he's healed and he's found his way out of it, but that's just one situation I run into.
So it's a very good example of how stigma plays into things and still comes up. We have fears of losing our job if we have an issue around substance use and acknowledge it and admit it.
Excuse me? I have something also to add to his story. I am a grateful believer in Jesus Christ, and I've married into addiction, which being in a family, I was raised in the Christian home, so I married into it. And a similar situation, not understanding it. And I'm so thankful that everybody is here and all these stepping stones to get where I'm at today, praise God. Because I was in marriage counselors, I was in Al-Anon, I was through many multiple avenues of this process and recovery. And it took, just like you said, being equipped, going through, I just look at the church as we're a trauma center for these people, and that we're not ignoring it, that God gives us the eyes to see these people that come in that are wanting the help. And praise God for the pastor that, acknowledged for you to come and speak, because it's so important to get in those those hurting places, and understanding, being equipped, being ready as the church to do this. And I am part of Celebrate Recovery in Tamaqua here. To God be the glory, because I'm not from this area. God called me to this area. But it takes one willing person to step into those places. So I just believe each of us is one willing person to step into that place and to be that person in the trauma center, being equipped, and that we don't ignore those people, because it has changed my life. It has changed my husband's life. It has changed my kids' life. It has changed our marriage. And through the grace of God and through the power of the Holy Spirit and Jesus Christ, that all these things were stepping stones to get us where we're at. So it is, the scripture that came to me was Romans 7:15. For I do what is right, but I don't do it. Instead, I do what I hate. And it's exactly what we do as humans. Like, that's what we do in our flesh. We don't want to do it, and we do it anyways. So it's the battle. And I'm just encouraged to hear that you are willing to step in. We have to step in these places, and they're uncomfortable, like we were saying here. It isn't comfortable, but we do it. It's real, and it's not easy. So it's really encouraging to hear. So thank you.
And real is what we need. That's going to be a huge part of it, is being real about what's going on and what's happening and how it's impacting all of us. Most people in a general community, and most people in a faith community as well, are going to know somebody who has an issue with substance use, experienced it in their family themselves, or have dealt with and lived through an overdose death and the repercussions of it. We need to, and all of you being here is showing that there's a huge identification of the need and a willingness to do something about it.
Takes an army.
Just to speak to this one more time, and I won't keep doing this.
Oh, no, it's okay.
My problem is it's just all this conversation always spurs these ideas and experiences that I've had. So in 2 short years of doing what I'm doing, I've run into all kinds of situations. One of the things that I do is I go to conferences that various denominations are having. So for example, a Methodist conference or Church of God and so on. And what I'm hearing there is we're trying to keep our churches open. We're trying to address other issues that pastors face continuously, but they don't have a solution or a program or a methodology on how to deal with substance abuse. So that's the first thing. So you're doing that here. This pastor is a second career pastor, retired, and he loves his church. He's trying to keep it open. It's a small church in the rural community of 30 people. 6 of the people are addicts out of 30. There's no Celebrate Recovery group there. There's no NA group. There's no AA group. In fact, they have to drive 30 or 40 miles just to find something, and they're very poor people. So this is not uncommon, and I've seen this in other congregations that I visited where it's a different denomination, different demographics, different part of the state, but it's all the same thing, same story, different people. And so the first thing that I'm seeing is what you said, it's not taught in seminary. I didn't learn it in seminary. It is part of congregational health. It's part of a plan to keep your congregation healthy. But the part that seems to strike me the most is the stigma part, which comes up again. So if I'm identified as a user and I'm sitting in that pew and I notice that everybody seems to sit further away from me than they used to, do I feel the love of Christ? And then when you're standing up there preaching to me about the love of Christ, I'm still feeling that gap get bigger. And that's what happens to these folks. And I don't have the solution to that in one answer, one statement. It's a number of touches, loving touches.
It happens some of the time. I have also, and we don't want to, there's 10% where that's the way it happens all the time. There's 10% where it's the most perfect response you can come up with. And 80% of the time, we're somewhere in the middle in our response to these issues. It's really a bell curve. Where it's going to happen is 10% people will condemn people for having a substance use problem and you're not a good enough Christian or whatever faith it is. 10% is going to be entirely accepting, loving, and do everything just about perfect in terms of how you could respond to the issue. 80% of us are in the middle somewhere trying to figure it out. Celebrate Recovery, and I may ask you a little bit later, if it's okay with you, to talk about what Celebrate Recovery does, since you shared that you were going, about what it is. It is an important resource that faith communities, Christian faith communities, can offer as an opportunity, and it is a wonderful program. And one of the biggest issues, like you said, is resources. That's where what St. Luke's is doing is unbelievably great in this community. More rural counties in Pennsylvania need that kind of assistance and support, where somebody like St. Luke's and their programming is working in the community to try to deal with those issues. Right now, I do a lot of work with problem gambling. I am a consultant trainer with the Council on Compulsive Gambling of Pennsylvania, and I train other counselors to deal with the issue when gambling becomes a problem. There are more counties in Pennsylvania than Gamblers Anonymous meetings. So trying to get to one for support and help isn't there. There's a faith-based Chance for Change program that's similar in a lot of ways to Celebrate Recovery for problem gamblers. But the issue is, if I identify I need help, where do I get it? And trying to figure out how to do that. And it can be a very big difficulty and challenge. What they've done in Lehigh County is some of the local churches have allowed a treatment provider, not us, but another treatment provider in our area, to use an office in the church to do assessments for people in the community when they need it and identify it, because you don't want them to have to drive to Allentown from the northern end of Lehigh County. So they've worked with, and some of the churches have said, we'll open space once or twice a week where you can do that assessment, connect with that person right in their community, and work with them to get connected. That's part of what the warm handoff programs are about. We work very closely with St. Luke's in Lehigh and Northampton County to go into the hospitals when somebody's there and do the assessment and try to place them before they leave. The fields move towards things like certified recovery specialists, which are people in recovery who take some training and are available in the communities to help with things like getting somebody to a meeting, taking them to their first meeting, making sure they get to appointments. So we're working very hard to come up with those solutions, and you're absolutely correct. It's not one thing. If it was just one thing to fix it, like we've said, we would have done it already. We have to have open, honest conversations about the issue, because I think that's where it all starts. And each of you sharing your experience is going to help all of us. So I really appreciate both of you for being willing to share those personal pieces of things, because that helps us in coming up with and looking at what can we do. Because having the knowledge and all that stuff without looking at what little step can we take after this, this training's not going to be a whole lot of help unless each of you takes a piece of it or gets together as a group in the community and says, this is how we're going to start addressing it. This is a step in the process.
My concern with faith is this. There are still communities of faith in Pennsylvania. Oh, sorry. I said my concern with, is it on? Concern with faith is this. There are still communities in Pennsylvania that teach people all you need is Jesus. I love the Lord, but this is misinformation. And to be preaching this and teaching this to people is just another example of leading someone into feeling like a failure, incompetent, and unable to be healthy. And it is just so detrimental to people's lives. And that education piece really has to be tenderly distributed to faith leaders, because there is still that being preached and taught to people.
And we have to help people understand that that helps us. But that doesn't mean we can't have a counselor. It doesn't mean we can't work on other things in other ways. I always have people ask me the question, because I have my degree in pastoral counseling, and they often ask me, are you a biblical counselor? And I always have to stop and ask them, what do you mean by that? And part of the reason I have to ask that is because there is a group of counselors from a Christian faith perspective who believe and have guidebooks that say, if you're depressed, read this verse, and this verse, and everything will be better. So if I tell people, I'm like, if you want me to give you a biblical verse that's going to fix it for you, I can't do that. That's not what I do. But if you want your faith and your belief as part of your process, that I can do. So I always have to clarify with people what they're looking for. And we have to clarify, and there's a number of articles that have been written recently that are out there on the internet that talk about, I'm a Christian, I have my belief, I have my faith, and I'm depressed. And those things aren't separate. Because I have faith doesn't mean I can't be depressed. Because I have faith doesn't mean I can't have anxiety. Or an addiction, or a gambling problem, or the other kinds of issues and problems we have around. And it's education and discussion about it. Yes, those things are very important and very helpful. Without the other parts of the person and addressing the other pieces of the person, they're still going to have struggles and difficulties.
I brought that up specifically because many people will not take medication as a result of
Yeah,
this.
and it's a discussion we have to have, is that, I can be on medication and still believe in Jesus. Those two things can go together. They're not separate and isolated. We wouldn't do that with any other medical condition. You wouldn't tell, well, I suppose there's a group who would, but it wouldn't tell you, don't get cancer treatment, Jesus will fix it. We wouldn't do that with most medical conditions. Some groups do, but not most. But we have to make sure we address the faith along with the other parts of it.
You raised the internet. Will you at some point in this workshop help us to, it seems to me that some kind of an A language sponsor or a guide or director, whichever model you want, because this we're a self-help age. You can write anything you want on the internet.
Yep.
Justify whatever they want. And at some point we have to deal with that, because we're talking about a model, there are some better and some worse practices.
Yes. Yeah, well, we'll talk about that some and look at some of the resources that are useful and helpful that are out there for us to be able to try to sort through that. I have some websites that are connected. I'm sure the two groups of counties that will be talking this afternoon will be discussing some of what's available on their websites and resources you can connect through them. Their websites, both Schuylkill and Carbon-Monroe-Pike's websites, are very helpful. I went to both of them in getting ready for today's training, and they have a lot of useful, helpful information on them. I think we're at around the time we were going to take break, so if we want to take a 15-minute break, we'll come back and continue our discussion.